Morning, good afternoon, good evening, everyone, and a very warm welcome to our webinar titled Antimicrobial Resistance in Conflict-Affected Settings, Field Realities, Operational Challenges, and Policy Recommendations. My name is Nelia Modruk, and I'm the coordinator of the AMR Multi-Stakeholder Partnership Platform. This is a global governance mechanism for multi-stakeholder collaboration, coordination, and action on AMR, established by the quadripartite and hosted by FAO. It's my pleasure to host today's session featuring the work of one of our members, Médecins Sans Frontières. Antimicrobial resistance, or AMR, is often described as a silent pandemic, but in conflict zones and humanitarian settings, it becomes anything but silent. The realities faced by frontline teams highlight the urgent need for coordinated action that bridges humanitarian response, global health policy, and local capacity building together. This is precisely why the work of the MSPP is so important. By bringing together governments, civil society, academia, and international organizations, the MSPP helps ensure the voices and the experiences from the field inform global strategies and practical solutions. The platform provides a space for multi-stakeholder collaboration, knowledge sharing, and collective problem solving that goes beyond sectoral and geographical boundaries. Today's webinar also takes place in the context of the World Antimicrobial Awareness Week, or WAW, and it's a reminder for all of us that AMR is a truly global challenge requiring awareness, commitment, and action from all of us. Our discussion today will help connect these global priorities with the realities on the ground. You will hear from experts and practitioners working directly in the field, sharing their challenges and the policy recommendations they believe are essential for progress. Thank you for joining us and for being part of this critical conversation. I'm looking forward to a dynamic and insightful discussion, and I hand over to Rupa Kanapati Pillai, Antimicrobial Stewardship Lead in the Médecins Sans Frontières, who will moderate this session with me today. Rupa, over to you.
Thank you very much, Nelia, and thank you all for joining us. I hope you can all hear me okay. I'll begin with a short introduction before we introduce our wonderful panelists. Conflict settings present significant challenges in addressing antimicrobial resistance, as you will hear from today's panelists. According to the UN, over 2 billion people currently live in conflict-affected areas where healthcare systems are disrupted, malnutrition is widespread, and displaced populations face overcrowding and poor sanitation. These conditions create the perfect environment for drug-resistant infections to spread, posing a growing threat to global health. Médecins Sans Frontières is an international medical humanitarian organization providing free healthcare to people affected by armed conflict, epidemics, natural disasters, exclusion from healthcare in over 70 countries. Over the past decade, MSF has implemented a multidisciplinary approach to tackling AMR in high-risk settings. This strategy combines infection prevention and control, antimicrobial stewardship, and access to microbiology-based diagnostics, which have been deployed in 25 projects across the Middle East, Sub-Saharan Africa, and South Asia. MSF has prioritized AMR interventions in projects with elevated risks, including reconstructive surgery, intensive care, neonatology, severe malnutrition, advanced HIV care, and other contexts with high rates of multi-drug resistant pathogens. In 2024, 40% of all of MSF's projects were situated in conflict-affected areas, with more than 1/3 directly supporting victims of armed conflict. These environments have seen alarming levels of multi-drug resistant infections. For instance, multi-drug resistant organisms were found in over 80% of bone infections in Iraq and 60% in Gaza and Yemen. Many of MSF's AMR projects are concentrated in areas affected not only by acute conflict, but also by its broader consequences, such as healthcare system collapse, malnutrition, and larger scale displacement. Examples include osteomyelitis treatment in Oman and the Central African Republic, as well as pediatric sepsis care in Yemen and the Democratic Republic of Congo. To address these challenges effectively, MSF deploys IPC and AMS experts to develop protocols, improve care, and train healthcare providers through initiatives such as the MSF Academy for Healthcare. Recognising the shortage of trained personnel in conflict and post-conflict zones, MSF has also introduced innovative tools like the AntiBioGo smartphone app, which helps non-expert lab technicians interpret antimicrobial susceptibility tests, and the Mini Lab, a portable microbiology lab that expands diagnostic capacity in remote settings. Despite these efforts, the scale and complexity of AMR in conflict settings are immense, and there is no one-size-fits-all solution. MSF is often the sole humanitarian actor addressing AMR in these environments, but the growing demand for support from ministries of health highlights the urgency of this issue. Responding to AMR requires a coordinated international effort. Collaboration between government, civil society, and global health organizations is essential to share expertise, pool resources, and generate context-specific evidence for sustainable solutions. Humanitarian actors like MSF play a vital role, but scaling up the response demands adaptability, innovation, and most importantly, collective action. As today's panelists will discuss, addressing AMR in conflict settings is a pressing global health challenge that requires unity and commitment to make meaningful progress. Thank you, and I will hand back over to you, Amelia, to introduce our first panelist.
Thank you so much, Rupa, for this insightful presentation of the work of the Médecins and Frontières, and for highlighting the need for collaboration and intersectoral collaboration specifically, and multi-stakeholder one. So, as Rupa mentioned, we have a very exciting line of experts today with us. And I would like to invite first Dr. Aula Abbara. So Dr. Abbara is Honorary Senior Clinical Lecturer and a consultant in infectious diseases at Imperial College, London, and an advisor on AMR in conflict for the Fleming Initiative. Dr. Abbara, warm welcome. Thank you so much for joining us today. And the floor is yours for your intervention.
Thank you very much, Niala and the team. And what I will do is just adjust my slides ever so slightly. And so I hope you see my PowerPoint, but if not, I might ask Niala to share that. So I would like to first start by thanking my MSF colleagues and the Quadripartite Joint Secretariat for organising such an important session, and the number of attendees accounts for just how strong the feeling is around the need for understanding and addressing the needs of AMR in conflict in humanitarian crises. So I hope you can see some of the pictures I have shared, but if not, I'm sure my colleagues can share them. But what I'd like to do is...
Dr. Aula, apologies, we don't see the slides yet.
Okay. In which case, I might ask Pauline to share them in the interest of time, and I will speak, and I'm very sorry for that. So firstly, as we talk about AMR and conflict, and what you'll hear over the next 90 minutes or so is us discussing some rather vast numbers. But what I want you to do is, as you listen to us, is remember that behind every number, there's a human being, there's a community, someone directly affected by AMR and multi-drug resistant organisms in a way that can be potentially life-changing and have significant and major impacts, both in the immediate term and in the longer term. There are children and adults with life-changing injuries for whom the skies are unsafe, for whom healthcare and humanitarian care is inadequate, and we cannot provide the needed diagnostics, we cannot meet the supply chains, logistics and requirements, and for whom the complex and sometimes limb-saving surgeries are inadequate, and where antibiotics cannot reach them, sterilization materials cannot reach them, to make sure that they get the best and most appropriate holistic care in some of the most dire settings affected by conflict and humanitarian crisis. And of course, part of this is AMR does not occur in isolation. These patients may have disabilities, they may have paralysis, they may have multiple injuries, as that we can see in some of the photographs I have shared. And particularly for children, this could well mean lifelong interactions with healthcare with many of the associated risks. But it also means interruptions to their lives because, as we see in Gaza, in Ukraine, and sadly many other countries, rehabilitation and prostheses, and many of the other needs that these patients have cannot be met for a variety of both man-made and other reasons. And what this means is they both face not only the immediate dangers and the immediate risks to their lives, not just by AMR, but by nature of their injuries, but as well as lifelong challenges, both related to infection related reasons, but also things that go beyond the clinical. And I really want us to think beyond the biomedical here. They and their families will face financial, psychological, and social hardships, which can have lifelong consequences both for them, their communities, and the health systems affected. Rupert alluded to the global burden in terms of people living in conflict settings. Beyond this, conflict is one of the most important drivers of forced displacement. This year, the numbers are unprecedented, with more than 120 million people displaced, many within their country borders, but also some outside of them, placing not only strains on the local health system, but often in the neighbouring health systems, whereby further strains on the ability to diagnose and treat infections is also impacted. And so if we go to the next slide, what I would like to do here is also encourage us to zoom out. And this is why the quadripartite meeting and this intersectoral collaboration and discussion is so important. So we must recognise the multiple ways in which AMR in conflict can develop. And conflict acts as an amplifier of the multiple factors which drive AMR. And you can see some of these pictured in the diagram here. Beyond this, I ask you not to think of conflict or context as a monolith. They vary by acuity, severity, duration, stages of conflict or post-conflict, and the contextual impacts on the populations, but also the complex social and political dynamics which exist in many of the contexts, many of the very challenging contexts that MSF and other humanitarian actors must engage. Sadly, as we see a rise in conflicts, what we're also seeing is a catastrophic and deliberate rise in destruction of healthcare and related infrastructure. This relates to water, sanitation, roads, electricity, and often with direct targeting of civilians, including children, and of required civilian infrastructure, causing multiple fractures in the pathways that are needed for our patients to survive and thrive in their lives. So I've noted that conflict is associated with massive forced displacement, and the strains of the health system, particularly where healthcare is attacked and destroyed, can negatively impact healthcare access. So particularly for people who are disabled, this can be profound. And the quality of the available diagnostics, particularly where laboratories are destroyed. And if we think about Gaza, almost all microbiology laboratories were destroyed just in the last 2 years. And this impacts our ability to care for our patients. And beyond this, what marks the study of conflict in AMR out quite profoundly is the extensive environmental contamination and the remnants of war. And once again, this will vary between Gaza, Syria, Ukraine, Sudan, and elsewhere. And this must be studied because I would argue that research on this is suboptimal. And we really do need to understand this to be able to respond appropriately to understand this complex problem. Importantly, there's increasing literature which suggests that heavy metals can co-select for resistance, and this can itself speed up the development of AMR faster than it would otherwise have done. Alongside this, the conflict-associated breakdown of water and sanitation in both community settings and in health facilities, in quality and quantity, can lead to increased transmission in both of these settings. In addition, and a very sad fact, that in this day and age, where patients may think that healthcare facilities should be protected, community may seek protection in healthcare, but of course, very sadly, we know that this is no longer a safe place to be. But what it does mean in conflict setting that there's an increasing mix between what we might consider community organisms and hospital-acquired organisms in a way that should not occur in areas outside of conflict. In terms of the forced displacement, and remember, many people, including children, may be forced to leave their homes or shelters more than once. There is vast overcrowding in tented settlements or unfinished building, inadequate for human habitation. There's breakdown in waste management. There's inadequate infection prevention and control, which can also lead to an increase in the transmission of multi-drug resistant organisms among populations. Thinking about our patients, and Rupa alluded to this, malnutrition and severe acute malnutrition weakens the bodies of our patients, which are already ravaged by conflict, adding further harm and increasing their risks of infection developing, poor wound healing, and also the risks of chronic infections, particularly where there is prosthetic material, which can lead to an increased risk of osteomyelitis, making it harder to diagnose and harder to treat, often requiring long courses and complex courses of treatment, both with antibiotics, but both with surgery as well. And wound care, as we have seen particularly in Gaza, where sterilisation and the consumables and bandages that are needed to keep these wounds clean are a dream in many of these settings, leading to increased risk of infection. And this is further compounded by the lack of diagnostics or poor quality antibiotics which come into the market, which may not be appropriate for patients. And these can act as a further driver of resistance in such settings. So in terms of diagnostics, I have mentioned the vast destruction in Gaza, and this impacts governance, it impacts IPC, it impacts stewardship, and ultimately the ability to provide quality healthcare and holistic healthcare for our patients. And beyond this, there are black spots in the amount of surveillance and data which we're able to gain as a result of this destruction and the breakdown of surveillance. Data in such settings is often sparse. There is data from Gaza pre-October 2023 in MSF-supported facilities, and that was already concerning. It showed that 65% of Staphylococcus aureus isolates were MRSA, and 30% of isolated gram-negatives were extended spectrum beta-lactamases, and 25% were carbapenem resistant. These are some of the end-line antibiotics which may or may not be available in settings such as Gaza because of interrupted humanitarian access. But even so, these make the infections affecting our patients even harder to treat. We can only imagine how much worse the situation is now, where there's not only the risk of immediate death and destruction, but also longer-term morbidity, longer-term preventable secondary mortality. I also want to draw on some of the work in terms of hospital environments from Reem Abu Shomar's work. So pre-October 2023, she screened water sources from 2 of Gaza's largest hospitals. And she showed that 34% of the screened water sources were contaminated, of which 22% were identified as extended spectrum beta-lactamases, and 11% were shown to carry the NDM gene, which confers carbapenem resistance. And this means that if you are in a health facility or a hospital, if you acquire a hospital-acquired infection, the ability to diagnose and treat becomes even more challenging. So what is it that I ask of the community that has joined us today? What is it that we need to do as a global community? So first and foremost, we must be clear that conflicts must cease. We must protect civilians and children and civilian infrastructure, and also the healthcare workers that are on the front line. Because without that, our patients and our communities and our health systems do not have the space to recover and rebuild. To address the current and urgent needs of AMR in conflict and crises, we need stable, low-cost, easily deployable, rapid diagnostics without interrupted humanitarian access, which are suitable to some of the most dire of the conflicts that we are working in. This can support individual case management and appropriate antibiotics, but also support us in being able to understand the burden. Humanitarian aid and access must not be interrupted, as these supply chains with antiseptics, antibiotics, medical materials and consumables are a lifeline for patients. We must also approach this across sectors with expertise from the diverse stakeholders for whom this topic is important. We must address the broader determinants such as water and sanitation and environmental contamination, but also the use of antimicrobials in agriculture and veterinary services, which are vastly understudied in conflict and post-conflict settings. because that will help us understand their role in transmission and how we can address them. We must also invest in our healthcare staff, who must be protected, supported with training, both for the surgeries and the case management that's required should infection take a hold. Beyond this, we must never think of AMR as being a vertical intervention. It should be holistic, because it's not something that occurs in isolation. As Rupa said, it can occur in neonatal ICUs and other ICUs and hospital wards in community settings and then onwards. And so the causes of AMR and conflict in humanitarian crises crosses sectors, and as such, tackling them require multi-sectoral coordination and collaboration based on the reality of the stark contexts in which we work. And so lastly, I'm going to return to my initial opener. We must centre our patients and our communities at the centre of how we approach AMR and conflict in humanitarian crises, making sure that their voices are heard, because without them, we will not understand how best to support them in their often long, traumatic and arduous journeys. Thank you very much.
Thank you very much, Aula. Excellent overview, and it really helps, I think, to provide a framework to what is indeed an incredibly complex problem with multiple drivers. And to have a way to even begin to name the various drivers helps us start to address how to address these various problems. We'll now shift our discussion to hear from two panelists who are providing direct support to projects. It's my pleasure to introduce Dr. Kalyan Velivela and Aula Abed. Dr. Kalyan has been working with MSF since 2008 and is currently a health program manager for South Sudan, Ethiopia, and Nigeria. And Aula Abed has been working with MSF since 2022 and is currently working as an infection prevention control supervisor in Gaza. Dr. Kalyan, I will address my first question to you. You're working as a health program manager, as I mentioned, across several different contexts: South Sudan, Ethiopia, Nigeria. Can you briefly describe some of these contexts and the systems challenges that you've encountered, particularly regarding diagnosis and management of patients with antimicrobial resistance? And as a follow-up question, can you propose some solutions to these systems challenges?
Yeah, thank you, Dr. Rupa. I'm very happy being here in this large forum. I just want to add some couple of thoughts and my impressions working with MSF and really from the field what we see. And as Dr. Aula presented that diagram of how conflict and AMR overrides with those multiplicities there. And in the context where I work and support, it's more, the crises are more compounded. It's multi-layered. We see everything coming together at once. And then the contexts are getting more complex. And when we say the crises are more protracted in nature. That's and we see the impact of displacements. This could be internally displaced populations, refugees, and not to forget people on the move. The impact of climate and environmental health is also coming up in many contexts. We see extreme climate events like flooding that has again an impact on everything. And we also see changing outbreak intensity, the scale, the scope, and the recurrence. And if we, for example, see in Eastern and in African context, cholera has been going on in multiple countries, and these outbreaks are more prolonged. Before, I remember working with MSF, we have a cholera, all of us respond, different stakeholders, and we stop the transmission and the outbreak is over. But I think we see a different pattern now. You know, the outbreaks and infectious diseases don't have boundaries like we have, right? And all this is happening in fragile health systems that have lack basic healthcare and standards. Aula already mentioned about we see a lot of poor water sanitation situations in the populations. And the big driver is also supply chain constraints. It's very hard in a conflict or in a flooding to have the supplies on a timely manner. And all this coming with reduced resources and funding, for health. That's from at the national levels and also how the external humanitarian landscape look like. To add, majority of the patients we see in our facilities are children, women, including pregnant, breastfeeding women and adolescents and neonates who are highly vulnerable and are at greater risk of seeking and accessing healthcare, especially during conflict and in humanitarian settings. The one who access care have delays receiving care. And in some contexts, we clearly see women walk hours and days to access healthcare for a very sick child, only to realize either the health facilities are non-functional, either there are no staff, or there are no medications. This also pushes patients and families not to seek healthcare until the child is very sick. That risks increasing infections and etc., and to rely on alternative options. Basically, they're seeking care in a local market, in a local pharmacy, or using traditional healers. Clinically, we are also seeing increasing complexity of cases, very sick children with worse clinical conditions. Dr. Aula mentioned in a lot of our projects, we see severe acute malnourished children with multiple medical complications. We admit them in our high dependency units and stabilization centers. We see neonates and premature babies, and 40% plus of the neonates that we see come with sepsis. And treating sepsis in that preterm babies or neonates is getting more and more complicated. And it goes on with patients with severe wounds due to trauma and etc. In hospitals and facilities where we have a microbiology, the antibiograms are increasingly showing high resistance to what we have in our arsenal. That's basically the antibiotics. And resistance, as Aula said, to Staph aureus, we named them Klebsiella. And we also saw isolates of Acinetobacter baumannii in a very remote setting, which is listed as a priority by WHO and a critical organism resistant to multiple antibiotics. We see them in a 5-year-old child. This gives us big concerns about what is happening. So where we have access to antibiotics, we are able to treat these patients. In other locations, it is challenging for our clinicians, not knowing what we are treating for. There are no options in the locations where we work to refer patients elsewhere for higher care because of the complexity of referring them, access issues, and etc. And also to be open with you, even in our settings, we lack appropriate antibiotics to manage such complicated cases. And on top of that, procuring high level of antibiotics is also challenging in many contexts because of regulations and etc., which is necessary. As MSF, our focus also remains in pillar 1, that's we are trying to focus on infection prevention and control, antimicrobial stewardships, where we work as part of providing quality of care. In secondary healthcare facilities, we're trying to scale up microbiology for AMR. Where we work in close collaboration with our other stakeholders and Ministry of Health, we continue improving structures. Basic built environment is very crucial to maintain minimal infection prevention. Building the capacity of on AMR, closely working with others. So I stop there. There's a lot to speak when we touch on AMR, but maybe if you allow, I can just quickly go through your second question. With all that, what we are hearing is, firstly, I think to me, understanding and a change in mindset towards AMR in conflict and humanitarian settings is very crucial, and it requires a multi-pronged, multi-sectoral approach. Health system strengthening remains a key, but we need context-adaptable, tailor-made, innovative approaches to dealing with AMR. And I just want to throw some few thoughts pushing through, and which Dr. Aula has already addressed, spoken them. I think firstly, important is improving healthcare access in conflict and humanitarian settings to those vulnerable and high-risk populations. It could be in many ways doing it. We have to strengthen the community and primary healthcare service delivery. We have to look in a people-centered approach rather than a disease or an individual, and focusing on prevention, early detection of infection, and appropriate care. We have to scale up interventions focusing on prevention. I repeat this, and that includes vaccination for vaccine-preventable diseases to improve coverage and prevent outbreaks. Wash, sanitation, and hygiene is paramount in these communities. We need innovative ideas. We have to be very practical, and we need some decent, good toolkit for managing AMR. And I start with surveillance. We need to increase our surveillance systems on identifying AMR, sharing data, and correlating it with environmental aspects as well. We need simplified protocols, how to identify AMR, how to diagnose, how to treat. And I give an example, and I really like the recent pediatric TB new diagnostic algorithm that was simplified. And that really helps the field workers. We should push for point of care tests. It could be rapid diagnostics and etc. to diagnose AMR. Cost-effective, field tested. Two last things, Dr. Rupa, is for me one of the keys strengthening supply chain and alternative mechanisms to avoid shortage of infection prevention control materials. It could be antiseptics, sterilization, laboratory materials, and antibiotics, ensuring supply is in place and consistent. And there could be many low-hanging fruit. In hard-to-reach areas, we should look into mechanisms of pre-positioning, drugs and having buffer stocks. And we have to also strengthen the regulations and local capacity, ensuring that there are high-quality antibiotics and medical products. Because we also see a lot of counterfeit, drugs and that are available everywhere. Lastly, support scaling up microbiology and laboratory capacity. That's what, at least we should aim for in selective healthcare facilities, that particularly wherever we have secondary healthcare hospitals to start with. So those are some of the things. I think we can speak about a lot of them, but out of my mind. But I'll wait. I look forward for if there are any specific questions also. Thank you.
Thank you so much, Dr. Kalyan. I will move to you, Aula, and shift the focus a little bit to IPC, knowing that these issues are all very interconnected. But to you, Aula, based on your experience, this audience recognizes the importance of infection prevention and control and addressing antimicrobial resistance, both in conflict and non-conflict settings. In your experience, what are the key challenges you faced while working in conflict settings on IPC? And as a follow-up question, can you describe some of the challenges with diagnosis and management of patients with multi-drug resistant bacteria? Thank you.
Hello all. So indeed, Ruba, before October 7th, we had established in MSF a strong IBC program starting in 2018 until 2023. We achieved a huge progress as their IBC audits that we did, the status improved from 23% to 94%. The situation worsened dramatically after the recent war. So during this period, I worked in more than 5 different facilities, and I speak today based on the different IBC assessment that I did and support I provided in those facilities in both North and later in the south of Gaza. in early acute stage of the war, there was a surge of injured cases in the north. With every displacement wave, it was becoming almost impossible to maintain the basic IBC measures. So some facilities designed for 250 to 300 patients per day were seeing 700 patients, that leading to extreme overcrowding. So despite designing a single isolation bed at PSCC setting without any partitions, it was ineffective. So due to the overwhelming number of cases. For example, Al Zawaida Hospital, Al Zawaida Field Hospital as well, all infected patients, regardless of the causative pathogens or the contact precaution required or any other precautions, were all housed in one tent. So another example, for example, the examination beds can't be properly cleaned between patients. There is no respect to the contact time because of overcrowding. Additionally, not all beds are equipped with the trolley. So you find two nurses doing two different dressing for two patients in the same trolley. And as well as the physiotherapist and wound care team had to work with the patients on the same bed, all while other patients wait for a vacant bed. So later we started to witness complete breakdown of the health and water infrastructure system. In more stable times, we used to outsource laundry to a nearby industrial facility. The facility very early was damaged first week of war, and reaching this facility during war was no longer possible. Some hospitals instead turned to domestic washing machine, which is not as effective as the industry one. Another thing that we mentioned, and it's important one, which is waste management also, which is collapsed. The Eastern burner destroyed, and it was not possible to segregate and safely dispose medical waste. Clean water as well, which is like a dream. The water infrastructure was damaged, and hospitals were using domestic water mixed with sea salty water. So the measure of dissolved solids like salts and minerals reached more than 7,000 in MSF facility domestic water. And for instance, Khan Younis PSCC, more than 8,000, knowing it should be less than 500. So this resulted in rusty surgical equipment and damaged equipment as trolleys, which is not available at all in all of Gaza and in war. Sometimes water was not available as well at all. And so patients, for example, in Deir al-Balah wound dressing tent, patients with wounds contaminated by sand because they are arrived to PSCC on carriage, were asked to wash in toilets that often have no water. Regardless, in spite of the dedication of staff and their commitment, we were also faced by extreme shortage in essential medical items. For example, alcohol-based hand rub were very limited in their availability. At one point, there were only 10 bottles in the central pharmacy. We had no blood stain enzymes at all. And instead, we had to remove blood stain with soap. Even then, soap was also a scarce commodity and become more expensive than gold, with one bar costing $30. We were rationing wound care materials as well. For instance, we were cutting the abdominal gauze into 5 pieces to cover the gap of the sterile gauze. And instead of cleaning wounds daily, we're doing it every 3 to 4 days for a clean, let's say for clean wounds, and 3 times weekly for infected cases, which should be done every day. I can go on and want to explain also the issue we had with other materials, like the lack of detergent and disinfectant in Al Shifa Hospital, making laundry not possible. and disposable surgical clips removal were not sufficiently available, and we had stock out for a long time, more than 90 days in some period. In these times of scarcity, the team reused the disposable one without sterilization because they are not made of material that can withstand the heat. For another problems or some problems with dressing scissors as well that were reused for both removing all the dressing and performing wound care, thus increasing risk of infection and compromising wound healing. So I would like to move to the next question, which about microbiology and diagnosis and management of patients with MDR. Before, when we had access like to microbiology labs in MSF was pre-October 7th, 2023, baseline AMR data very high, 60 to 70% of bone injury resulting mostly from gunshot wounds were multi-drug resistance, and as Dr. Aula mentioned. In 2022, 60% of the bone and tissue isolates among patients with osteomyelitis were multi-drug resistant. 65% of staph aureus were methicillin resistant. 25% of resistant enterobacteria were resistant to carbapenems. Even then, such cases required continuous follow-up for 2 years, and the cure rate was very low. Treatment for such patients with resistance is difficult, as about 60% of essential medicine was inconsistently available. Stock out affected access to antibiotics, and this was especially the case for novel antibiotics. And today, available laboratories report very high rate of multi-drug resistant organism. However, laboratories lack access to stable supply of equipment, electricity, and water. Most laboratories don't have the capacity to run bone and tissue samples. So most testing is done on swab culture, so they are less accurate. The lab has limited availability to the equipment, so staff have to wash and boil and reuse the petri dish to conduct cultures, which increase the risk of contamination and false results. And despite not being able to confirm whether which resistance rate we are seeing, we can already see increased rates of infections among wounded. On average, 18.3% of new wounded patients had infections and have reached as high as 37% in some supported facilities. Doctors without access to microbiology prescribe empirically, although we have established empirical treatment guidelines at the beginning of this war that have been created according to a multi-drug resistance organism rates found before 2023. So it was not possible to provide broad spectrum antibiotics due to stock out and storage and shortage. In most cases, the only available option was amoxicillin clavulanic acid, which doctors use despite its limited effectiveness in treating MDR wounds infection. Thank you.
Thank you so much, Dr. Aula, for this insightful overview of the situation on the field. Indeed, very difficult and not easy. And along with what we have heard from Kellyanne, basically, we understand that we need to have the improvement of healthcare access, specifically for the vulnerable people, the importance of prevention, the importance of surveillance, the importance of IBC and WASH and water and all the infrastructures. So we have heard that indeed the situation could be very difficult, very disruptive, depending also on the different contexts, right? At the same time, we have heard that there are solutions, that there are activities going on. So my question would be to both of you, Kelly and Ala. So there are challenges indeed which are unique to specific contexts, and we have heard that, and there are those which are more universally applicable, we would say. So what are the key messages that this audience today would need to hear from you, and what we as the society can do? What is the role that we can play to address these challenges? What, for example, would be the message to policymakers, to the researchers, to the civil society? What should we retain basically from what we have heard from you? Over to you, maybe Kelly, and then Ala.
Yeah, no, thank you. I think pretty much until now, all the speakers have said, to me, I feel like the AMR in conflict or humanitarian setting is right there. It's in front of us and we are already dealing with it, and we don't know what we're dealing with it in some context. And it's we need to be very critical about it. And in my opinion, if we're able to prevent and address the drivers of AMR, we are in fact strengthening the health system, and it's a vice versa approach. We're talking about access and all the elements that you have already highlighted. And it cannot be done in silos. A multi-pronged sectoral approach and a collective action is necessary. And what puzzles me sometimes, to be very open, if we see the humanitarian landscape is ever changing, crises are happening and more protracted. The needs are massive and ever growing. And if we see the funding for conflict and humanitarian setting, it is in a downward trajectory. We need the dedicated commitments from national authorities, humanitarian actors, UN agencies, funding agencies in specific, to continue and expand the financial support for humanitarian responses, and probably including dedicated focus on AMR. And I just want to highlight one or two thoughts. I'm not sure how many of the countries, while we speak about this, have dedicated policies addressing AMR. How many have a roadmap or how we want to address an AMR? Maybe we should start thinking about it in a bigger picture and learn from each other. And as we already spoke, we have a huge academia, we have a huge scientific community. How long would it take to have simplified toolkits? How long would it take to have point of care and rapid diagnostics that can be cost effective, that can be field tested and used in conflicts and humanitarian setting? I think we need to push those agendas. And pretty much my last take is, I really thought about it when you asked the question, Ella. I thought, like, it's a vice versa. If we are able, I repeat this, if we are able to prevent and address the drivers of AMR, it's actually we're building and strengthening the entire health system, and it's a vice versa. And it has to go in hand. There's so many things we can do, we should be doing, and it's more commitments and acting on them rather than speaking. And I stop there and over to yeah. Thank you.
Thank you, Killian. So from my side, I have been told in times of crisis, I should deprioritize IBC. But it was clear later that even basic measures we took improved the situation. So we need to start considering IBC a priority even in terms of a crisis and conflicts, and adapting the program to suit such context. So it's also important to expand access to quality, reliable microbiology to improve outcomes for patients, that will likely suffer the consequences for years to come. Finally, immediately ensure the uninterrupted supply for critical medical and hygiene material to uphold basic infection prevention standards, and invest in restoring fundamental infrastructure, including clean water, sanitation, and waste management system, which are essential for preventing the spread of pathogens. So we all have a role to play, including governments and the humanitarian actors. Thank you.
Thank you so much to both of our colleagues and panelists for your really insightful reflections of the realities of working in these incredibly complex settings. Thank you for these very vivid depictions of some of the challenges. I'm going to shift a little bit now to a bigger picture perspective, and to really frame the question, it's my pleasure to introduce Dr. Mohammed Shafi Fazaluddin Koya, who is a medical officer on antimicrobial resistance and infection prevention control and One Health for WHO EMRO. Welcome, Dr. Shafi. Dr. Shafi has nearly 2 decades of global health experience, including with WHO, MSF, development banks, private sector universities, and ministries of health. Dr. Shafi, to shift the focus to a bigger picture perspective, how do we take these multiple challenges and address them at policy level? Over to you.
Thank you so much, Rupa, and thank you so much for all the organizers and agencies and partners for this discussion. I was listening very carefully to what Aula was mentioning, and of course Kalyan, and of course Aula. We had also the opportunity to discuss with many of you when we were trying to develop something as like some clear layout of policy options and considerations for bigger institutions that should be playing much bigger role than what they now, including development banks and partners. I think, I will start with what Aula was mentioning. If I understood clearly, there is always, IPC is not a priority in emergencies. Is something which I think when we were trying to develop with a lot of partners, including MSF and other development agencies, to see like what can be, sort of, advice to all the bigger humanitarian actors. I think the most important thing that came up is about infection prevention and, interventions. So if we really need to improve the containment of outbreaks and be prepared and ready for, strengthening our response, I think we need to have fragile conflict situations, specific minimum IPC considerations. And we cannot expect huge burden on healthcare workers to do how we are doing in terms of monitoring the compliance. We need to have simplified tools to help monitor and assess how we are doing in terms of IPC. The WASH facilities in healthcare facilities and we have heard from colleagues from Palestine and Sudan and Ukraine in multiple discussions, the issue of clean environment, waste management, absolutely difficult in the current situation. I think we need to have tailored approaches. We cannot have the global usual standards that we can do. I'm not saying that we need to have lower standards, but we need to really tailor them to the context that we are operating. Vaccination often gets ignored. I think that's very, very important that we have clear, strategies and investment to improve vaccination context. So infection prevention is really the number one. We heard about the testing, the difficulties in testing, especially we heard a lot, particularly from Gaza. We need to have improved access, and we have some of the opportunities. For example, I would say, the AA-enabled tools like Antibio were developed by MSF, for example, which can be easily deployed. Even when we do not have trained medical microbiologists in some of the situations, we know it's difficult. And we have started to work with countries, and I think this is something which we strongly advocate as an important option. We need more tools, more such tools to improve the field level availability of mini laboratories and mobile or field level opportunities for testing. There are opportunities, for example, in Gaza. We knew that there were still, even under this most horrific situation that we are talking about, it's quite unusual even in a war situation, we had opportunities to have mobile facilities if we could have mobilized some resources. In the beginning of the current conflict in Gaza, one of the most important difficulties for our clinicians and our request that we had was about treating wound infections. Other community-acquired infections, okay, it was still okay, but there was really a need to put together evidence and quickly to guide clinicians on how to manage severe wound infections, which are quite unusual in the current conflicts. Everywhere we are seeing the current conflicts. So I think that's, again, an important thing to be considered. And we need investment. We did some ad hoc work, but that's not enough. We need real investment to get it done correctly. Surveillance. Of course, lab is one aspect, but we also need to know that we have the early warning, alert, and response systems. How can we integrate multi-drug resistant organisms and healthcare-associated infections efficiently into the E1 system is a critical question. We need investment. We need trainings. We need simplified tools, which, of course, the E1s is already there, but we need to embed them and help our clinicians and facilities to really help in surveillance of this. And also, we need to do surveillance of antibiotic use to make sure that we have appropriate use of antibiotics. We also know that there are existing tools, like, for example, the humanitarian response package. We have the WHO medicines package. Are these packages and systems in line with the globally, talked about access watch reserve classification of antibiotics, for example? Do we have, for example, nitrofurantoin in the commonly used packages in our emergency kits? See, these are things which are like very simple interventions, but we need the organizations and institutions to focus on. I cannot talk about policy options and interventions unless we talk about community engagement. We know that even in the midst of the horrific conflicts that is happening, we have a stronger community engagement, and that community engagement starts not only with, it's not just about the general population, but also the community of practitioners, the community of the gatekeepers, and also the general community in general. We need to have them engaged. We need to be prepared in terms of training our first responders in vaccination, hygiene, appropriate use of antibiotics, probably, which is something which is missing in our training of first responders, unless it is in a very common, normal situation. Adherence to dosages. We know the stories that come out from our conditions, but I think it's important to have that community engagement element. We need the local voices to be mattered, and we need the communities and frontline providers to be part of the solution. Mobile and primary care, MSF operates a lot of such service provisioning, and we understand over the period. For example, in Sudan, we had a really a opportunity to engage with the mobile care. We need to have more integration of such services in primary and mobile care. It's not just for conflict, in the active conflict, but also, as I think Kalyan mentioned, we need to have that embedding the AMR activities into the primary care, which is very essential for sustaining some of the activities in the long term, even protracted conflict situations. And of course, enough has been told already about the wider determinants of food security and safe housing and waste management. To do all these things, maybe I'll take one more minute and stop here. We need to really consider what are the predetermining factors which many of these solutions we know has to happen. It's not happening, in fact, in the field. It's because of supply chain disruptions. And of course, financing, especially the financing of established roadmaps, for example, the humanitarian WASH roadmaps. How can we make sure that we have a stable supply chain? And of course, how can we strongly, somehow I feel that, over the years, seeing a lot of these conflicts, somehow we forget that even in war or in conflicts, there are certain rules. And there has been really exemption when it comes to attack on healthcare institutions and hospitals and healthcare workers. I think we need to bring back very strongly the discussions It's not just for AMR, but I think it's very, very critical to keep talking about that. You cannot have healthcare institutions and healthcare workers, targeted in any conflict. Thank you.
Thank you very much, Dr. Shafi. We will transition now to open up to Q&A with panelists. By means of introducing this next segment, to summarize, we have heard how antimicrobial resistance poses an imminent threat, especially in fragile and conflict-affected settings. Addressing this crisis requires collaboration across civil society, governments, humanitarian actors, United Nations agencies, academia, and donors. Key priorities include embedding AMR mitigation into health system strengthening and emergency response plans, integrating IPC into conflict responses, investing in operational research on antimicrobial resistance in volatile settings, and ensuring the safety of healthcare workers and medical suppliers. As we move into the Q&A session with our panelists, I encourage us, the audience, to reflect on two critical questions. And thank you for those who have already put questions in the chat. How do we position ourselves to address antimicrobial resistance effectively in these contexts? And what additional action should we push for to ensure sustainable and impactful responses? Perhaps we could start. We have several questions in the chat. I think we can try to group some of them together. One of the questions, the most recent question that was posted, was what are the key drivers and field challenges of antimicrobial resistance in conflict and humanitarian settings? And thank you, Aula, for providing this excellent framework. Especially considering limited diagnostics, displacement, and weak stewardship practices. Aula, please, or anyone else on the panel, please feel free to respond to that. The second part of this question, which I think is the key question, is what urgent, practical, and scalable policy and operational actions can humanitarian agencies and governments take to strengthen AMR surveillance, improve rational antibiotic use, and enhance infection prevention and control?
So Rupa, I'm happy to make a start if that's helpful. And thank you very much, Nasser, for the question. I think you capture what I think all of us are thinking, because we don't want to be theoretical, we want to be practical. So when you're working in a very resource-constrained setting, and we've alluded to the humanitarian access challenges, we need to be based on the ground reality. I'm a big believer in some standardization, but very importantly, understanding the context and then working with the local healthcare workers, the local logisticians, and of course our local patients to understand what it looks like from their perspective. And so in this particular instance, I try to bring together some of the sort of ground level challenges that impact AMR in real time. But remember, I said we lack diagnostics in these instances. We sometimes lack the ability to properly survey. So one thing I'm going to bring in here, so when I ask a doctor in Syria, do you think AMR is a problem? They will say yes. But then if I'm being analytical, I'll say, but actually we don't really have the laboratory data to properly back this up with good quality data, because of course bad quality data can be misleading. I am going to say here that AMR in Syria is a problem. But that becomes really important. It becomes nebulous. I think someone was also asking, why does AMR not get the same priority as some of the other conditions that we see in conflict? Trauma, emergency care, neonatal ICU, sexual and reproductive health. All of these are incredibly important. But to an extent, it can be a bit more insidious unless, of course, you're seeing someone deteriorate in front of you with severe sepsis that you can't treat with appropriate antibiotics. But a lot of the time, remember, we alluded to chronic osteomyelitis and some of the more indolent but no less important infections that we need to manage. I really enjoyed listening to all the presentations, especially Aula, who's giving us an important ground level reality check, if I'm honest, and Dr. Sherfi, who's bringing in some of the more broader policy aspects. What does it mean for humanitarian organizations in the field? This is important, and I think here we really need to be clear. Médecins Sans Frontières is one of the most important of the humanitarian organizations that's still working on and prioritizing AMR. Many of the other international organizations, because they relied on different funding streams, find themselves unable to invest in and prioritize AMR. And I won't name names, but my colleagues in some of the really important international organizations who are AMR and infection specialists no longer work in those roles, which is a huge loss. So they don't have the same ability to work with IPC, for example, or stewardship. Coming back to what this means in the ground reality, it has to be contextualized. It is that balance between making sure the right antibiotic is given to the right patient in the right way, in the right time, when it's suitable, but not giving antibiotics when it is not suitable. And that's why when I ended, I really said we need to invest in our clinicians and our health workers who are at the front line making these very difficult decisions. I'm pleased to see that we have increased social science research exploring with these healthcare workers what it's like for them. It's easy for me to sit in my ivory tower and say, well, you can't give antibiotics unless it's absolutely necessary, fulfilling these criteria. But remember, in a conflict setting, if something happens to the patient, that healthcare worker could be at risk, or they could be criticized, or their reputation becomes at risk. So I'm going to summarize it by saying what it means in that particular context. We can do antimicrobial stewardship. It can be making sure your switch from IV to oral is appropriate. It can be making sure that the durations are appropriate. It can be making sure, and I think we need to go back here to about 100 years to remember that quote that was in one of the old ICRC textbooks. When you have, so surgery is the best antibiotic. So we need to be very careful. Antibiotics are not alone the best treatment for a conflict-associated wound in these dire settings. It's about surgery, it's about wound management, it's about aseptic technique, it's about good nursing and good care for our patients. And we know this is difficult, but it doesn't mean we can't invest in all these really important holistic aspects. It means good nutrition for our patients, if that is possible. And we know in Gaza that has not been possible for a variety of both man-made and other reasons. I can say much more about this, but I will stop because I can see a great number of very important questions coming through.
Thank you so much, Aula. So maybe I can try to take other questions in the chat box. And indeed, thank you for highlighting the need for this holistic approach and multiple services around to ensure that we can provide the best support possible in the conflict setting. So let me try to look into other questions that we see in the chat. So there is Karin saying that it's very sad to hear these observations from different conflict-affected settings, but at the same time hopeful to hear the different efforts. So, and she agrees that we need a simplified and tailored approach for such complex situations. And perhaps questions to Aula, how was the situation of IPC at the community level as well? So we have heard the importance of that level as well in the discussions. And another question from Wati Paso, in humanitarian settings where lack of access to antibiotics is as dangerous as misuse, how do we balance stewardship with life-saving access, especially when clinicians must make empiric decisions without diagnostics? So I don't know who would be happy to answer these questions. I think this is for all the panelists. Maybe starting with Dr. Aula and...
Yes, I would like to answer the first question from Karin. So IBC in communities, the first thing is more dangerous, which is the water and sanitation system, which is I mentioned in hospital or healthcare facilities, but also in communities, the water and sanitation system broke down at all. And the bombing has destroyed all pipelines, sewage pumps, and treatment plants. And the minimal available water is often contaminated. So I believe that you already know the breakdowns of IBC has led to outbreaks of water like borne disease, for example, hepatitis A virus, acute jaundice syndrome, and severe diarrheal disease like cholera and watery diarrhea. So also, which is because of crowdedness and a lot of times to people to be displaced from place to place. There's also respiratory infections, people living in tents, and there is a winter weather, so upper respiratory infection become more and more in winter season, and it's already started within the last month. So mainly the influenza and yes, and also for skin disease as well. The most skin disease that already spread very quickly, which is scabies, lice, and fungal infections due to the lack of hygiene, because there is no water, so there is no clean clothing and stuff like that. As also as well as vector-borne disease, which increase risks of disease from flies and mosquitoes, from the garbage, which is like mountains in middle of Gaza city in the north, as the waste management is broken at all in north of Gaza, especially in South Gaza city. And the last one is about the wounded infections, as I mentioned at the beginning, and the infection rates become increased in some points because of the reasons that already I presented at the beginning, and especially for a lack of antibiotics and sterile dressing. Also for supply chains, as all borders closed and there is no any type of medical consumables already enter Gaza city that make IBC materials, especially soap, chlorine, disinfectants, detergents, and PPE, personal protective equipment, which is an important part for as a standard precautions. It's already not available or let's say not affordable. Yes, this is for the question from Karine. Thank you.
Can I add something quickly to follow that with regards to the guidance for clinicians and frontline prescribers? I think to echo the sentiments of several of the panelists, I think we have to start by defining the problem, and that comes to documenting the rates of resistance and the type of bacteria with quality assured microbiology. I think what we see is that there is really limited good quality data from these conflict settings and post-conflict settings for a variety of reasons that Aula, I think, outlined very well. But we need to better understand what we're dealing with when we're talking about treatment with antibiotics for infected wounds. And I would advocate that should be prioritized in terms of research agendas, but also to have some reflection on that data, to have a coordinated approach to protocol development between major agencies that are humanitarian actors and others that are working in these settings, to have some coordinated approach with regards to guidance documents. I think there are efforts to move this forward, but I think that's essential. But as Aula also said, surgery remains the mainstay of management for many of these, and we can't do good surgery without good IPC. We can't do good IPC without supply chains. but I will go back to our long list of questions. Sorry, we have a question about practical strategies to implement and reduce overprescribing of antibiotics, particularly through stronger clinical protocol development, improved diagnostic stewardship, and targeted capacity building for prescribers. Would any of the panelists like to speak to that question? That could be bundled with other targeted interventions if we had to prioritize a handful. What handful of targeted interventions should be prioritized?
I'm happy to answer, but I'm also happy to give space if someone else would like to. But I might bundle this. There was a very good question, I think, from Noor Shamas earlier. And what she was really asking is, when we deploy healthcare workers to humanitarian contexts, and also for our local health workers, and remember, they form the vast majority, we've heard superbly from Aula today, and many of her colleagues, they are at the coalface. They are the people in these settings. And we don't do enough to provide them with the education and training, because remember what we've seen in October 2023 onwards in Gaza, what we saw at the start of the Syrian conflict, what we saw at the start of the escalation in Ukraine in the last 2 or 3 years, and then in Yemen and Sudan from April 2023 is, and it wasn't necessarily stable before or without conflict before, but the scale that conflict puts on healthcare workers, both surgical and non-surgical, results in a learning curve. At the start of the Syrian conflict, we found that surgeons were putting internal fixators into open wounds. That's a big no-no for infection. It's not something that we do. They were trying to limb salvage large bone defects. And that comes from the fact that they are not trained in the surgery required in these sort of conflict or traumatic settings. And so I speak about surgery because it's more obvious, because we see the catastrophe more obviously. But remember, in many of these settings, we don't do enough to equip our healthcare workers. And remember, these aren't infectious disease specialists or microbiologists, because they don't exist in many of the contexts that we work. These are general healthcare workers, whether nurses or advanced practitioners, or general doctors who've just graduated, or sadly, medical students have been forced into the most difficult of circumstances. So this becomes twofold. Remember, when I said that conflict is not a monolith, there are times in conflict, and I might draw on Syria here, where about 14 years of conflict just about ended in December 2024. I don't think we're quite in a post-conflict state in many parts of the country. It was not always acute conflict, and therefore there were times where we could do education, we could do AMS, we could optimize IPC, not in all settings, but in some of the settings that we could access. So this is one of the things that we can do meaningfully in these settings. Gaza is obviously catastrophic and quite different, but there are certain times and certain facilities where it is possible. And actually, I don't think I need to say this. This is coming directly from my Gazan colleagues, who themselves are saying they want to do some sort of stewardship. They want to do some sort of monitoring for surgical infections. They want to do monitoring for antimicrobial resistance, remarkably, even in the depths of what they're experiencing. So again, adding to what I've said before, but putting in some things around protocol development. Remember, the WHO has some important protocols that are in place. Médecins Sans Frontières has, which are appropriate to the local, what we know about the local microbiology in these settings. But it also goes back to what we need in these settings. I don't think we are quite there with the easy to deploy, low cost, not requiring much skill, rapid diagnostics that will help us, even at a basic level, understand what we're dealing with in that particular setting. And then, of course, there becomes something important beyond protocol development, which is the implementation, the monitoring and evaluation and the usage of some of the protocols we put in place. Before we go to Kalyan, I'm going to add here, and I think I saw this somewhere in the questions, are there protocols, are there plans at a country level? So if you study the national antimicrobial plans for countries, even in countries affected by conflict and displacement, this is not always mentioned. Or if it's mentioned in passing without acknowledging the profound impact of conflict and humanitarian crises on the development of AMR and the particular needs that are in place. And of course, we know that national action plans may just be written down and often not implemented, but at least starting to write them and discuss them and having the right people in the room becomes the start of a discussion. And again, before we go to Kalyan, one thing I learned yesterday that has stuck with me is a lot of our discussion today has understandably been through the lens of health, with mention of environment, with mention of nutrition. And of course, this is so fundamental with our colleagues in the quadripartite joint secretariat. I attended a World Antibiotic Awareness multi-sectoral meeting in Damascus, the first of its kind in Syria this year, as part of WOW. And this was remarkable. I learned yesterday that, and I'm embarrassed to say that I didn't know this before, which means that perhaps some of my colleagues here may not know this. Around 70% of AMR in some of these settings is as a result of practices in the veterinary industry. And actually for us as healthcare workers, this is often a blind spot. And again, when we talk about conflict in AMR, we don't characterize this well. In Syria, we're starting to characterize environmental impacts of multi-drug resistant organisms and agricultural practices, but we really are at the start of what is really important in terms of evidence base and then what we do with this particular evidence. So Kalyan, over to you.
Thanks, Aula. I think you pretty much covered. I just wanted to highlight one is specifically on the humanitarian settings, not the, even in MSF, we are learning, where we do think we have that capacity because MSF brings in some resources and etc. We are learning a lot. Are we perfect? No. With all the staffing, the trainings that we do, the close support supervision we do, the mentoring we do, we still have a long way to go. And some of the colleagues asked in the question on how do we balance stewardship and empirical, how do we balance life-saving? To me, if we go with do no harm, I think infection prevention control and stewardship are fundamentals, basically. As a clinician, and as healthcare workers, we should not do wrong, right? We try to avoid doing, not doing wrong. And I don't want to give an antibiotic that's not working or that's not, appropriate. What we learn in MSF settings is basic adherence to protocols. There are so many protocols from national, ministries of health, WHO, actors. How is the adherence to protocols? And I think that is pretty much a basic thing if we want to cut down the overuse of antibiotics. Having basic, simple clinical audits going on in inpatient care, in surgical wards, in pediatrics, etc. And how do we learn from it? So I do think definitely even in emergency settings and even in outbreaks, we have shown, at least putting minimal standards of infection prevention and control and stewardship activities. And it can be done. Pillar 1 and Pillar 2 are pretty basic. I think we can do that. And I can also add, I want to add, yes, we want the efforts and to push for point of care, simplified tools and diagnostics. But we also find it challenging to have microbiology everywhere. These are cumbersome, these are expensive, and needs human resources, etc. So for that, we need specific tools in our toolkits to how do we simplify our algorithms? How do we have more effective diagnostics? But I think there are so many low-hanging fruits we have to push through at different levels of care. in conflict as well as in post-conflict settings.
Thank you so much. I'm raising my hand because I'm very conscious of time, and I would like to just answer one question about the characteristics of an ideal drug to address in conflict settings. This is something that we've thought quite a lot about within MSF and with our MSF Access colleagues. I mean, for us, really, we need to focus on the problem that we're seeing, which is mostly multi-drug resistant gram-negative. So the most common pathogens would be extended spectrum beta-lactamases, as well as MRSA, the harder to treat because there's limited options for particularly prolonged treatment for the ESBLs and the carbapenem producing gram-negatives are the biggest challenge that we face in terms of tolerability, but also affordability. And I think the ideal would be a safe, effective, tolerable drug in formulations that could be better deployed in difficult circumstances, such as oral formulations, particularly for multi-drug resistant gram-negatives. That's the dream, as well as pediatric formulations and heat-stable formulations. But that's a whirlwind tour of antibiotic needs. I will take the 1 minute that we have to try to close. Apologies in advance, I might go a little bit over time. But thank you so much to our panelists and to the MSPP and the organizers for putting this very rich discussion together. I will try to conclude some of the points that were discussed. So as we've heard today, and as MSF observes daily, there is an urgent need for stronger multidisciplinary response to antimicrobial resistance in fragile and conflict-affected settings. Also critical is generating the data and research necessary to make these interventions effective and context-specific. There are several multilateral efforts underway right now that have potential to accelerate progress. This week, we all received more information, for example, on the establishment of an independent panel of evidence for action set to be launched in December. If the funding and governance of such a panel was sufficiently inclusive of affected communities, free of conflicts of interest, and therefore able to direct expertise and resources towards filling the most pressing evidence gaps, particularly those that prevail in fragile and conflict-affected settings, it could meaningfully inform response to AMR in these contexts. Likewise, the ongoing update of the Global Action Plan on AMR and the upcoming ministerial conference in Abuja next year potentially represent key opportunities to bolster the response to the challenges we've heard described today. Through the Global Action Plan, for example, we could articulate more ambitious and concrete targets for scaling up diagnosis, such as the goal of expanding access to diagnostics like pathogen identification and antimicrobial susceptibility testing to at least 80% of populations as proposed by the MAP study group. And at the ministerial, countries could finally muster the collective international resources needed to achieve such new commitments as well as existing ones, including meeting WHO's target of 90% of countries, achieving minimum IPC standards by 2030 and addressing gaps in access to antimicrobials. Lack of access to both first-line antibiotics and critical last-line agents is a huge issue in fragile settings. And resources and international commitment could advance solutions, including diversified manufacturing, pooled procurement, humanitarian pricing, and support for diagnostics and stewardship. As these multilateral initiatives develop in the coming months, it will also be crucial to integrate AMR responses with broader measures like WASH, vaccination, and nutrition, as today's panelists also made clear. However, the global retreat from multilateralism and significant cuts in international health and humanitarian funding cast doubt on these efforts, despite commitments in last year's UN high-level meeting to raise $100 million to support LMICs in implementing national action plans. Many donor countries have reduced contributions to essential programs like labs, vaccination, WASH, and TB and HIV care. This isolationist trend is incompatible with the solutions needed to address AMR in fragile and conflict-affected settings. What's required is strategic, international collaboration, not withdrawal, strengthening vulnerable healthcare systems, not fortifying borders, and respect for international humanitarian law. For interventions to succeed, they must be patient-centered and tailored to the unique needs of individuals and communities in crisis settings. AMR in these contexts is a grave but varied threat. Targeted quality care is essential, not only to protect patients in fragile settings, but also to preserve the efficacy of antimicrobials globally. That's it for me. Thank you very much to all.
Thank you so much, Rupa. Thank you so much to all the panelists, to all the participants who attended today's meeting. We hope it was a useful one, so we will share the recording after this meeting and all the materials shared. And happy WOW, stay safe, and have a good evening or day, everyone.